Good evening and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us tonight. I'm Derek Pease, the manager of digital marketing at Treese Medical Concepts. Treese Medical is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get right into the presentation by tonight's surgeon speakers, Dr. Mindi and Paul Dayton of Ankeny, Iowa. First of all, you are listening to the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We will be answering questions sprinkled throughout the presentation and revisiting them at the end for a Q&A session. We will also be emailing you out an archived link of this presentation to refer back to within just a couple of days. Lastly, I know that you will enjoy our speakers tonight, but if you're attending outside of the Ankeny, Iowa area, you can find locally trained Lapiplasty doctors in your own area to consult with by visiting our patient website, lapiplasty.com, where you will find a prominent Find a Doctor button at the top of the homepage, searchable by zip code. As I introduce tonight's surgeon speakers, I want to remind you all and just call out that their experience is extensive, having performed over 1,000 procedures between the two of them. Doctors Mindi and Paul Dayton of Ankeny, Iowa, have a unique passion for bunion surgery correction, as well as providing their patients with the highest level of foot and ankle care and the best patient experience possible. They opened Foot and Ankle Center of Iowa Bunion Surgery Specialist in 2018 after many years of research and experience with a different approach to bunion surgery, with the vision of becoming the preeminent bunion surgery center in the country. Along with the Foot and Ankle Center of Iowa Bunion Surgery Specialist, they own Midwest Bunion Centers, which focuses on bunion surgery research and consulting with a mission of improving bunion surgery outcomes for surgeons and patients alike across the country. They have worked hard to amass a top-notch team at Foot and Ankle Center of Iowa that shares the same values and has the same goals of providing elevated patient experience. Since 2009, since 2009, they have researched the anatomy and the cause of bunions that have been instrumental in the development of breakthrough techniques to improve the reliability and quality of bunion surgery. Together, the Daytons are pioneers of triplane bunion correction. Dr. Paul Dayton is a co-inventor of the Lapiplasty and Ductoplasty systems and is one of the founding Lapiplasty design team surgeons. Important to keep in mind that Lapiplasty is a surgical procedure, and only a surgeon can tell if the Lapiplasty procedure is right for you. As with any surgical treatment, there are risks and individual results may vary, and recovery does take time. This experience is unique and specific to these patients only that you see highlighted. Potential risks include infection, pain, implant loosening, and the loss of correction with improper bone healing. For more information on the benefits, risks, and recovery, again, you can visit lapiplasty.com. The surgeons tonight are paid consultants of Treese Medical Concepts, and the opinions expressed by these doctors are their own and not necessarily those of Treese Medical Concepts. So with that being said, I'm going to turn this over, and as I mentioned, we will return at the end to moderate a question and answer segment at the end, but now I leave you in the capable hands of Doctors Mindi and Paul Dayton. Thank you very much, guys.
Well, thank you, Derek, and we'll take ourselves off video here shortly because you don't need to watch us the whole time, but we just wanted to be on video to say we're super excited to spend our evening with you. This is a passion of ours, so you're kind of getting to spend a date night with us. So
that's true. Our date nights many times are reviewing our next paper that we're trying to publish or the next research. So yeah, very excited to be here. Obviously we love patients. That's what we do every day. We love talking to patients and we love educating. So any questions that you have, there may be a lot of questions, but any questions that you have, we'd love to try to touch on all components of bunions in general.
Absolutely. So give us just a second because we are really good at bunion surgery and technology. Okay, so we got it. There we go. Hopefully we should be off. So we'll dive into this. And as Paul mentioned, we want to answer your questions. So please post your questions. We'll kind of keep a little bit of an eye on that as we're able to as we go throughout the discussion. But then at the end, we'll definitely make time for the questions that you have. But bunions, what are they? We've all heard the old adage of, the old grandma, my bunion hurts. And traditionally, we thought they were just a bump. Well, they're much more than a bump, and we'll definitely hit on what they are in a few moments. But the typical symptoms that patients are going to experience include pain at the big toe joint, sometimes swelling. There can be nerve pain and nerve kind of numbness or tingling because the nerve happens to sit right over top of where the bump is at. And they obviously can be worse or feel worse if you're wearing shoes that crowd the toes or you're standing on your feet for long periods of time. But the misconception then is that this quote unquote bump can just be shaved off. That's something that we did as a profession a lot in the past before we really understood what was going on anatomically with the bunion. But now we know, as you can see on the slide there at the bottom red arrow, that the root cause of the bunion is really an unstable joint in the middle of the foot. And so if we don't understand that and we don't address that, we're unfortunately not going to be able to give patients the best long-term outcome.
Yeah, and I think really the best way to look at it is, we talk about, if I had a bunion, I would be going in to have my bunion removed. But we really don't remove a bunion. We actually correct the deformity that caused the bump or caused the bunion to begin with. So really the most important thing about the understanding of bunions is why do they occur to begin with? So we know bunions run in families. They're hereditary. That's very clear. And so what is the genetic or hereditary component about a bunion? And we believe, and research would indicate that it's the bottom red arrow. There's a problem with that joint. And that's really one of the tenets of Lapiplasty, one of the reasons why we treat the bunion at that joint where the arrow is, because there's an issue with that joint allowing the foot, when it moves, to push that bone out of position. And that leads us to what bunions really are. They're really not a bump. It looks like a bump. It feels like a bump. It rubs in your shoe like a bump, but it's really a complicated deformity.
Yeah, and because it's more complicated, we really need to understand the anatomy and make sure that we're addressing all three planes, and we'll talk about what those are, kind of the movements of the bunion. But if we're not addressing all components, then again, we're not setting the patient up for success long term. And again, as Paul kind of mentioned, with respect to the genetic predisposition or hereditary, shoes are not the cause of a bunion. We just had this conversation actually with Montel Williams recently. We were fortunate enough to join him on a Lifetime TV show, The Balancing Act, and he shared on that show that he has a bunion, and he was worried, did I wear the wrong shoes? But shoes don't cause this. Now, shoes can absolutely make the pain worse, and they can, in theory, kind of speed up the progression because they're putting abnormal forces on the toes. But it's really based on, as I say to patients, how you're put together, what you're born with, that's going to lead to the bunion.
So it would be great if bunions were just a bump and we could just go in and kind of shave it off, take a little sander or a saw and just shave it down. But unfortunately, that's not the case. And it really gets a lot more in depth than that. And, the thing that most foot and ankle surgeons were trained in, and I was trained in, is this idea that we can just shave the bump or just kind of move the bone a little bit. But we believe, and we've found through many years of research and treating patients, that if we don't really look at the foundation, right? The foundation is the most important thing about your house. That's what keeps it standing. if we don't look at the foundation of the bunion, which is that joint, again, the arrow that's below pointing to that joint, if we don't address that joint, then really there's a lot of issues with bunions coming back and all kinds of other problems that we see. And it would, we use this Leaning Tower of Pisa animation, and I think it makes a lot of sense. If we were going to straighten up the Leaning Tower of Pisa, obviously we're not going to go up to the 3rd or 4th floor and cut the building in half and just slide the top of the building over. That's not going to correct the problem. And that really is very much in line with how we see bunions. We have to correct it all the way down at the foundation of the bunion.
Absolutely. And bunion surgery is not for everyone, and it's not for everyone at every point of their life. So there's definitely non-surgical treatments that can help keep patients comfortable until they either decide it's time to fix the bunion, it fits into their life or recovery, or again, if they're not a good surgical candidate. So we oftentimes talk to patients as well about shoe fit, padding, spacing, orthotics. But the unfortunate thing is that these are not going to fix the deformity. They can't fix the bunion. So while in some patients they can help minimize the symptoms and keep them comfortable, they're not going to solve the problem. And so that's when we really have a discussion with patients regarding how much is this affecting your quality of life and your activity. And interestingly enough, before we kind of figured out what was going on with bunions and worked on developing Lapiplasty, Paul and I used to tell patients, wait until the foot hurts so bad you can hardly walk to do anything surgically. Do all these conservative treatments first, because we weren't confident in the outcomes we were going to get with the traditional 2D osteotomy. And now with the approach that we have and the solution we have with a 3D correction with Lapiplasty, we can feel confident in the outcomes that we're going to give to patients. So I tell every patient, obviously there's no emergency bunion surgery. So you have to fit this in when it makes sense for you, if it makes sense for you. But it's exciting now because we can feel confident in the outcome that we're going to be able to provide a patient and the function that they're going to achieve after their surgery.
And that really leads to one of the things that Mindy and I are super passionate about, and that is researching our results and our technique. And Lapiplasty has had a very robust amount of research done to show what the long-term outcomes are. So, we really feel fortunate that we have a procedure that has been looked at and researched, and we really feel like we have a pretty good handle on what the results are. So when we talked a little bit about traditional bunion surgery, and so this is what we would term a traditional bunion surgery, or a cut and shift, a two-dimensional procedure. And I'm sure most of the people on the call are not foot and ankle surgeons, so I'll try to talk you through this. But what's been done here is the side of the bone, the metatarsal's been shaved, and the bone's been cut in the middle and then kind of moved over, and a couple of screws are put in place. But when you look at the progression over the first 4 months and then at 4 years, you can see that the separation between the metatarsals, you can see those two little bones up underneath the front part of the joint are nowhere close to normal alignment. And this is what we saw, unfortunately, all too often with the techniques that we were doing, previous to Lapiplasty with the traditional type techniques. And, this honestly, when you look at a foot, it looks a lot like a bunion after the correction. And so with Lapiplasty, we take a completely different outlook, a completely different approach. We're leaving that metatarsal bone completely alone and normal, but we're moving the entire metatarsal bone back into position. And so that's really a key tenet of the Lapiplasty procedure. And at least Mindy and I firmly believe that that's one of the reasons why our results have gotten so much better. And again, back to the Leaning Tower of Pisa. So we're not going to cut it at the fourth story and shift it over. We're going to take it right at the base, and we're going to fix that foundation and push it back into position. So we feel that this is restoring a normal anatomy or realigning everything. And it's a complicated procedure, and that's why instrumentation or tools were developed to be able to do the procedure. And so this would be a typical result. So if you remember back to that slide of the traditional result, you'll see the two little round bones in the previous slide were out of position. And if you look at this correction now, those two little bones, which we call sesamoids, are right where they should be, right lined up from the inside to the outside of the joint. You can see the big toe is nice and straight, and that metatarsal bone, which has been realigned at its foundation, is right where it should be.
Yeah, and when I'm reviewing this with patients in the clinic and I have the pre and post-op, just like you see here, I'll cover up those plates and screws. And if you didn't see the hardware there, the post-operative film looks just like a perfectly normal anatomic foot. And by placing the patented plates across that joint, we're stabilizing that unstable joint that allowed the bunion deformity to occur to begin with. So this is really a large part, both the component of the sesamoids, those are those little white bones that Paul was mentioning, getting those lined up, and then also stabilizing the unstable joint is really the crux of what allows us to give patients a good long-term outcome. Because not only do we have to have the bones lined up where they should be, we have to have the soft tissue lined up where it should be, and the tendons. And if we don't have the joint stabilized in the middle of the foot, and we don't have those sesamoids, which I kind of liken them to like a kneecap and how they function with the big toe, if we don't have those lined up underneath of the first metatarsal at that big toe joint appropriately, that means the tendons are going to still be pulling in an abnormal direction, and unfortunately increase the likelihood of the bunion coming back.
So we wanted to give everybody a little glimpse into the operating room. So we do many bunion corrections every year, and we use the instrumentation from the Lapiplasty system, and we wanted to show you what the system does to realign. So just to give you a preamble, so there you can see some metal pieces over the bones. You can see that there's a bunion. You can see the little round bones, or the sesamoids, are very out of position. They're not sitting under the head of that metatarsal. And so our goal is to move that metatarsal over, to de-rotate it, and also make the big toe straight. And so the instrumentation allows us to seamlessly realign everything back into position. And that really is one of the biggest, what I think is the biggest breakthroughs in the Lapiplasty technique, is that we're able to take that deformity and just dial it back into position. And then once we have it in this position, we put the plates that Mindy talked about, the patented plates, on to hold it there, and the bone heals, and hopefully the results are what we see here, which is a bunion which is then restored back to a very normal position of the sesamoids and the metatarsal bone.
Yeah, and the unique thing with Lapiplasty is not just the joint that we're doing the procedure at, because there are other procedures that are done and ways of doing a procedure for a bunion at the same joint that we're doing it at. But as Paul mentioned, the instrumentation. So the instrumentation, which is, and we'll talk about this a little bit more later, but is FDA cleared and has been since 2015, that allows us to get these reproducible, reliable results time and time again. In the past, before we had the instrumentation and before we really understood the 3 dimensions, because previously, even if a surgeon was doing surgery at this joint, we were usually only addressing 1 or 2 of the planes or components of the deformity. So with the understanding and the instrumentation, we're able to address those 3 planes consistently, which is really what makes Lapiplasty a game changer and unique from any other procedure that's out there or any other instrumentation that might be available as well.
And, really what it's all about is, we want the foot to look better, of course, but we want the foot to work normally. We want it to function normally. And if we can get that metatarsal bone and those sesamoids back in position, then we can get the big toe back where it should be, straight again. And you can see in these results, which are really typical Lapiplasty results, that the foot looks completely different. It's much more narrow. The big toe is sitting in its, normal or anatomic position. And, you can just look at these and to me, when you have this normal alignment, you can equate that to a patient that feels better and that has normal function. So Mindy talked a little bit about the Lapiplasty system. So the Lapiplasty system is not investigational or experimental. It's been cleared by the FDA for use since 2015. There's actually been over 75,000 Lapiplasties performed across the country. And it's a procedure that is designed really with the patient in mind. That's what we love about it so much, is it's designed with the patient's outcome in mind. And it's a patented procedure. Actually, there's many patents that are issued for all components of the instrumentation. And the procedure itself is a bunion procedure, so it is actually covered by Medicare and other insurance companies.
Absolutely. And as was mentioned earlier, with respect to the patents and not being investigational, again, you can feel confident that surgeons have been doing this procedure for many years. Oftentimes we get, well, this is new. Well, the instrumentation and the philosophy is new, but the idea of bunion surgery, is not. But this procedure and the instrumentation, one thing that I love about Treese, who has the Lapiplasty system, is that they're so focused on education for surgeons. And so in order to perform a Lapiplasty procedure, you actually have to go through additional advanced training and hands-on training with the instrumentation. And so that's why it's not offered by all surgeons, because they haven't gone through the training. So if you see a surgeon and they say, oh, well, I don't do Lapiplasty, but I do something similar. Well, Lapiplasty is Lapiplasty, and what the results that we have been able to publish, as Paul mentioned, the research, are based on the instrumentation. They're based on the patented fixation that we use. And so, if somebody's telling you that they're doing something similar, we don't know what those results will be, because that's not based on what we've been researching and studying for so many years. And if you're looking for a surgeon in your area, now granted, we love patients, we love doing bunion surgery, so we're happy to, Des Moines, Iowa is a great place to be, but we realize not everyone can come to Des Moines to visit us, though if you're interested, we have a process for that. But there's a great tool on the lapiplasty.com website where you can find trained surgeons in your area that have gone through the advanced training and have performed the procedure, so you can feel confident and comfortable that you're going to a Lapiplasty trained surgeon.
So what about recovering after surgery? So I can tell you, and probably most of the participants on the webinar have heard the horror stories about how difficult bunion surgery is to recover from and how painful it is. And I can tell you, one of the priorities for Mindy and I know it is for Treese as well, is to make the recovery as painless and as seamless as possible. So everything we do revolves around making sure that the technique, that the instrumentation, that the plates that we use to fixate allows our patients to get up and around as soon as possible. So In our practice, we have our patients in their boot at 4 days, starting to bear weight in a limited fashion, and then it progresses on over time. On average, within 2 weeks, most Lapiplasty surgeons have their patients weight bearing in a boot in a protected fashion. And the majority of patients, especially in our practice, but I know in others, by 6 to 8 weeks are transitioning back to a comfortable athletic shoe. And this is bone surgery, so we have to protect that bone while it's healing and let it get strong and let it get back to normal. So we generally do not recommend any high impact sports like running or jumping until about a 4-month period of time. But when I compare, what we're doing now today with Lapiplasty to how I was trained to do a bunion operation, our patients are recovering so much quicker than they could before. We don't put our patients in a cast. We don't require them to use crutches and stay off of their foot all day long. They have limited periods of time where they can be walking and using their foot and moving their foot and getting back to normal activities.
Yeah, and that is obviously makes the recovery much more palatable, but it also, improves your overall function and well-being and emotional health, which is really important after surgery because it can be a straining time for a patient. And in our practice, we're really excited. We have a multimodal pain management approach that we use. So in our practice, our patients typically need very little to no narcotics at all, which obviously if we can avoid that is good for the individual and society as a whole also.
So what happens if you don't treat a bunion? And we get asked that all the time. The first question is this going to get better over time? And the answer to that is pretty clear, that bunions, again, are a hereditary problem. So we believe the problem starts at that joint. We should have put a red arrow down at the bottom joint there, but we believe that it starts at that joint. The joint is not formed correctly. That allows the metatarsal bone to move out of position. And that progression, it just doesn't stop. It's a progressive drift of that bone over time. And so you can live with a bunion your whole life, but if you do, it's very common to see other things happen. Number one, arthritis is very common if a bunion goes on for decades and decades. Hammer toes, pain under the front of the foot, bone spurs, there's many other things that we see. Now, that doesn't mean that every single patient that has a bunion has to have it corrected. And again, as Mindy said early on, we used to tell patients, wait till the bitter end, but we were telling them that because honestly, we really didn't have a method that we were confident in, that we were confident was going to solve the problem long term. And that really has changed in our practice. It's changed because now we have a technique that has published results of upwards of 97% successful results at just under 2 years time frame. So that's pretty exciting now that we can offer it at an early stage and maybe avoid some of these things over time.
Absolutely. And Paul mentioned, arthritis. So the longer a joint is malaligned or out of position, it's going to create wear and tear and can lead to arthritis. But the great thing about Lapiplasty and the Lapiplasty philosophy and our three-dimensional approach to bunion surgery is that we have solutions for bunions with arthritis. We have a solution for bunions with an associated deformity. It's called metatarsus adductus, big fancy term for, instead of just your bone behind your big toe being deviated in towards the middle of the body, both the first, second, and third are deviated in. And in the past, I know a lot of surgeons, and myself included, would just tell a patient sometimes, that's too difficult to fix. We can't do it, just live with it. But now with the Lapiplasty philosophy, again, we have solutions. So no matter what type of bunion you have, no matter what associated deformities with the bunion, we can use the Lapiplasty philosophy and the 3D correction to get same or similar outcomes that we can with just an isolated Lapiplasty procedure.
And that's great. That actually leads us into a couple of the questions that have come up over and over again. Is how do you know if you're a good candidate for the Lapiplasty procedure? And the true and honest answer is there's no way to know without visiting a surgeon. You need a consultation. You need an overall evaluation of your foot, ankle, and lower leg. We look at things like circulation and strength and many different things. And of course, x-rays, because we need to identify, is there that arthritis associated? Is some other deformity associated? But all of these things can be determined by a consultation with a surgeon. And like Mindy said, the really exciting thing about Lapiplasty is we really have developed solutions for all of those contingencies, for the arthritis, for the big old word metatarsus adductus.
Yeah, and oftentimes we get the question, well, I have a small bunion. Is Lapiplasty right for me? Or as you can see on the slide, is my bunion too severe to be treated? And the answer is every bunion is potentially a Lapiplasty candidate. And we don't think, at least in our practice, of bunions in terms of severity, mild, moderate, and severe. And the reason we don't think of that any longer, we used to in the past, but the reason we don't think of that any longer is because whether the bunion is in its early stages and mild or whether it's severe, those patients still have what we believe the root of the deformity at that middle of the foot joint, at that what's called that tarsal metatarsal joint. They have probably a genetic abnormality of that joint. And so whether it's mild, moderate, or severe, we want to fix it and stabilize that unstable joint. And whether it's mild, moderate, or severe, we want to be able to fix all components of the deformity, all three planes, as we've been saying, or the terminology that we've been using. So for our patients, Lapiplasty is the bunion solution, because no matter what, it allows us to get those reproducible, reliable results for our patients.
Something that Mindy and I deal with quite a bit, since our practice over the last 15 years has really changed to where most of what we're doing is bunion correction. We do see a fair amount of patients, probably about 20% of our patients that are coming in for evaluation because they've had another bunionectomy, usually a 2D bunionectomy, and they haven't had the result that they hoped for, and so they're coming to us to see if maybe Lapiplasty can help with that problem. And in our practice, we have had great success with using this Lapiplasty philosophy, the instruments and the plates and fixation, to be able to either recorrect or help improve on the correction from a previous surgery. Now, these can be a little bit more complicated cases. Sometimes there's a little bit of extra, evaluation or a little bit of extra that we need to do in the surgery. But we've had great success with using this platform, this philosophy, to be able to then improve on results that may not have been optimal in the past.
Absolutely. And we've hit on all these points that you see there already, but why is Lapiplasty different? Just to reiterate, our goal is to correct all components of the deformity, and we want to stabilize the unstable joint without cutting the first metatarsal in the middle of it, because the first metatarsal itself is a normal bone. It's just in an abnormal position. And with our patented plates and how we specifically position those plates relative to the bone and relative to the foot, that is what allows us to get our patients walking very quickly, which allows what we believe an improved recovery in so many facets.
Yeah, we find that getting back onto your foot early helps just about all components of our patient's recovery.
Swelling, nerve pain, absolutely.
Less sensitivity, less swelling even when you get walking early. We like our patients to be out of their boot whenever they're sitting and always when they're sleeping, so they're foot, their ankle, their leg can move. And we've just found that's such an important component of improved recovery. So all of that, great news. This is surgery. Obviously, as surgeons, we talk about this every day, day in and day out. We know the results of Lapiplasty. We know the percentages of success are very, very high, 90 percentile region or range, but it's surgery. So there are potential adverse effects. And with any surgery, it doesn't matter if it's your thumb or your toe or your knee, there's a chance of healing problems, there's a chance of infection, certainly there's a chance of pain and discomfort, nerve pain and other problems.
Absolutely. And that's just something that, each individual patient needs to discuss with their surgeon. You need to understand the risk going in because, as Paul mentioned, we consistently see excellent results, but each patient is going to heal differently. And there's a lot of different factors that go into surgical outcomes and recovery. So just make sure that you are well informed and you have those open discussions with your surgeon regarding, in your particular case, what are some things that could happen, and be aware of that.
And I get a question, or I get questions a lot from our patients. They look at the plates and screws and they ask, well, what are those made out of? And so the plates and screws, the fixation is made out of titanium, which is, it's not new in medicine and in bone surgery, but it's newer, and we find that it's very compatible with the body. But that being said, there's no two patients that are the same, and you can see sometimes loosening or even failure of the implant. Luckily, in our practice, that's very, very infrequent. But those are things that certainly we talk about with our patients, and other surgeons do as well.
Yeah, and of course, one of the questions always is am I going to make the airport metal detector go off? And I guess I make up a word. Paul tells me it's not a word, but I say it's not metallurgic. I guess that's not really a word. He's the metal and wood guy, but it won't. So for those of you concerned, it won't do that. And in our practice, we find somewhere between 5 and 10% of patients, and that's what our studies are showing as well, need to have hardware removed and or want to have hardware removed. And the times when it may need to be removed is, if just based on your foot structure and your anatomy, if it might rub in a shoe a little bit, they're very low profile, they're not very thick, but if you don't have a lot of padding there, sometimes it can be irritating. And sometimes for patients, they just don't like the idea of having it in. But the good thing is that it's pretty uncommon to need it removed or feel the desire to have it removed. And also, if we have to remove it, we do that once the bone is fully healed. So once your bone is healed and locked in that stable position, the hardware is just along for the ride. It's not doing anything any longer to quote unquote brace or hold the bone in the right position. So we can remove that hardware through a pretty simple procedure if it has to be done without the risk of your bunion coming back or your bone shifting out of position again.
So other questions that are very common, insurance coverage. This is not, again, an experimental or investigational procedure, so it is covered by standard insurance payments for this. The codes for Lapiplasty are standard foot surgery codes. So, of course, this depends completely on your insurance. Every insurance company has different rules and regulations, but by and large, this procedure is covered by insurance companies.
Yeah, well, that's our passion, that's our life. So thank you for letting us share a little bit about Lapiplasty with all of you. I know I said we would kind of try to look at questions throughout, but it was hard to see because they were so small on our screen. But Derek is gonna now kind of walk us through some of the questions, and we'll continue to hang around and answer those.
Yes, thank you both so much for a wonderful presentation, very thoughtful and informative, and we really appreciate that. So it was terrific. As you mentioned, we've had several questions come in this evening, and More and more are coming through now as I see them ticking across my screen. So I thank you for the great audience participation. We'll do our best to answer most, if not all, the questions that have been submitted. If you haven't yet, as a reminder, you may ask a question by clicking on the questions tab in your control bar and typing it into us. Before I turn your questions over to the doctor, just to reiterate a quick question that's come in repetitively during the presentation, and I'm sure will again, and that is the Lapiplasty procedure covered by insurance and or Medicare? And just to reiterate, the answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover the bunionectomy and joint fusion procedures that utilize the Lapiplasty system. If your doctor determines that the Lapiplasty procedure is right for you, he or she can reach out to your insurer to determine your specific level of coverage. Also, if you are joining us and still listening in and we are not able to get to your question, if you have to leave for any reason, you can also submit your questions to patientinfo@treece.net. Again, that's patientinfo@treece.net, and we can always get back to you with an answer as well. So with that being said, we'll start kind of going through some of these and do our best to answer them and get to them. So one of the first questions is, will there still be the appearance of a bunion after the Lapiplasty procedure?
So that's a great question. And our goal, and what, at least in our practice, what we attempt to achieve is once you're fully healed, and it takes 6 months to a year for your body to fully recover from any surgery, no matter what it is. Our goal is to not have that appearance of that bump by the big toe or that quote unquote bunion. Now, early in the process, there may still look and feel like there's a little bump there, and that is due largely to swelling and thickened soft tissues from the toe being out of position for so long. And the body is crazy. It has this ability to really fix itself in many cases. And so as that swelling resolves over several weeks to months, and as that soft tissue normalizes from being in an abnormal position and stretched for so long, then we anticipate that the bunion or the bump will be gone and the toe should be straight.
Terrific. And this is another good one and a common one. I've seen this a few times. Can you do the Lapiplasty procedure if a patient has had a previous chevron surgical procedure, or similarly any other kind of failed bunionectomy? Can the Lapiplasty procedure still be done?
The answer is yes. In many cases, we couldn't say in every case because it depends on what the positions of the bones are, whether or not there's arthritis. But as Mindy talked about a little bit in the presentation, so Lapiplasty has several components. So we talked mostly about the component where we're just moving the whole metatarsal over, but that doesn't cover the patients that have arthritis in their big toe joint and that other big word, metatarsus adductus. But the Lapiplasty family has solutions for that too. So if patients are coming in and they've had a previous chevron or other type of osteotomy procedure, yes, in almost all cases in our practice, we can correct that, but it may not look exactly like the pictures we showed you, depending on how good a shape the big toe joint was in. So the answer is yes, but
with an asterisk,
maybe an asterisk on there. Yes, exactly.
The key to that is we can give you a straight toe with a functional foot. It just might look a little different than the x-rays do, but yeah. Same functional outcome and pain relief, yes.
Very well answered. And this is one I'm sure you both have received plenty of times, and it's definitely come through here more than once this evening, but can I get both feet operated on at the same time? Or how long should I wait between having the second foot done?
So here's I had this conversation with 3 separate patients in the office today. We see many patients with bunions, and it sounds really attractive to just get it over with, right? Let's just do them both at once and let's get it over with. And it's not a good idea. I can just tell you, I can do both sides at the same time, but you don't want me to. It's a very difficult recovery because now you have two boots on, you don't have a good foot to be up and around. And we find in our practice, honestly, that patients do much better having one foot done at a time. They've got a good foot, they're up and around much quicker, they're more active quicker. The whole recovery tends to be better. That's just our experience. So we don't do both feet at the same time, and that's really for the patient's benefit, not for anything else, because we really feel that it's a tough recovery both at the same time.
Absolutely. And then typically we'll do the second side about 4 months after the first side. So once the patient's back into their shoe, kind of back walking normally, they've shown that they've been able to get back to their life and doing whatever activity they want to do without any concerns or complications, and that's when we'll proceed with the second side.
And just so we're clear, they're back in their shoe at 6 weeks, but
Yes,
back in their shoe and back to
normal
full unrestricted activity, not thinking about their operated foot anymore.
Thank you. That was a very, very good answer. I think that probably answered a lot of the questions that came through, and that's why I appreciate the detail there. This is kind of a multi-part follow-up, kind of ties into when you actually have the procedure done, and it's, is this an outpatient procedure? How long does it generally take, and will I have to be fully knocked out, or is it general anesthetic used?
So those are great questions. I'll try to unpack them. So yes, it's an outpatient procedure. Here in the United States, I know Canada sometimes has, well, they don't have Lapiplasty there, but there's different rules, but here in the United States, it's an outpatient procedure, whether it's at a surgery center or an outpatient hospital facility. Being knocked out, or the anesthesia, is really going to be your surgeon's preference. It will be everything from what's called a conscious sedation, so kind of like you're getting a colonoscopy where I tell patients kind of in Lululand, not knowing what's going on, all the way through a general. We in our practice tend to use a general regularly. General is very, very safe. You don't have to worry about feeling uncomfortable during the procedure or moving around, but that's really going to be surgeon's preference. And the full spectrum is safe and reasonable for patients. I don't know, was there one more part of that question? I felt like there's 3 things, Derek. Did I miss something?
Yeah, they were curious how long the procedure generally takes. Understanding that there could be other pathologies that are being addressed at the same time, but somebody was just getting a Lapiplasty done.
Absolutely, and it truly does, if we're fixing hammer toes or a flat foot or other things at the same time, that's obviously going to increase the surgical time. But once a surgeon has become really comfortable with the procedure, somewhere around an hour, give or take. Every patient is different, so sometimes their anatomy is just perfect and it goes like clockwork and we're out of there in 40 minutes. Other times they have a little bit interesting anatomy, and it takes a little bit over an hour. So somewhere around an hour, give or take, if you're looking at just an isolated Lapiplasty.
And great, and you started to even lead into a couple of next follow-up questions, and so thank you for that. If somebody has other issues, a hammer toe, a Taylor's bunion, bunionette, can that be done, and can those be addressed at the same time as the Lapiplasty procedure?
Yeah, that's very, very common with patients that have bunions to have other associated problems, especially hammer toes, Taylor's bunion, which is kind of a bunion type of thing on the outside of the foot rather than the inside of the foot. So yeah, it's not uncommon that we will address those other problems at the same time that we're doing the bunion surgery, because they're really related. There's other more complicated structural issues back in the foot and leg that we will address in some cases as well, because again, they're all mechanically related to the bunion. So, but the short answer is yes, we do associated procedures many times.
Derek, if I can jump in, I see a pretty
Absolutely.
good question here. Just immediately after the surgery, how does the patient get around? Well, for our patients, as Paul mentioned, we get them in a boot about 3 to 4 days after surgery. So the first 3 to 4 days before they're in that boot, they're largely using crutches or a knee scooter with a little bit of weight on their heel for balance and transfer and get off the toilet safely and all of that. And then once they're in their boot, as you mentioned, we let them start walking around for light activity, kind of activities of daily living. But the first 2 weeks, give or take, depends on the patient. If they're going to be doing a lot of activity, going a long distance, up a lot, then either crutches or a knee scooter tends to be what most of our patients use. Obviously, some choose to use a walker as well. Knee scooters, from a patient standpoint, those knee scooters, unless you have obviously significant knee arthritis, are fantastic. And you'll see people buzzing around faster than I can practically walk on them. So they allow, our patients that are teachers and, not manual laborers, but people that do have to be up and around, to go back to work pretty quickly. So.
Yeah, just to be a little more specific, we encourage our patients to be on their foot with the boot 10 minutes out of every hour while they're in the boot. So that's the first 6 weeks. So that gives you a flavor that you can get up and, take care of yourself. If you work in an office, you can go back to work sometimes in the first week or 2 weeks and be up and around for short distances. And anything beyond that 10 minutes per hour, then we recommend that our patients use a scooter or some other device to keep the pressure off. It's good to be weight bearing some during a recovery, but too much can be a problem.
That's terrific. And while we're on the subject of kind of recovery and post-op protocol, because we had some people join late, so I know some of these we may have touched on a little bit, but when can I, if it was on my right foot, when would I be able to drive again? And how soon can I get my foot wet? Whether that be showering or, actually going in a swimming pool, knowing that swimming is a much different activity than, showering, and a little bit more physical.
Those are great questions. And obviously every surgeon is going to have a little bit different protocol for this. Our protocol for driving on your right foot is we don't want you to drive for 6 weeks. And not only because we want you in the boot, but actually there's some decent studies showing that your reaction time and the safety after foot and ankle surgery of driving within that 6 weeks is harmed. It's not safe to drive within those first 6 weeks after a pretty significant surgery. So we say 6 weeks if it's the right foot. So, beg, borrow, and steal somebody, that owes you a favor to get around to your appointments or to work. And then as far as getting the foot wet, we let patients get their foot wet after their first post-op visit. So that's going to be about 3 to 4 weeks. This is
3 to 4 days.
3 to 4 days. Sorry.
3 to 4 days.
Yes, 3 to 4 days.
3 to 4 days.
Thank you. So after that first visit, we let them take their dressing off, put a really light dressing and or just a sock on if there's no drainage, and they can start to shower. So just normal shower, let the water and soap run off of it. Not a problem with that at all. As far as swimming and keeping the water or the foot submerged in water for any period of time, in our practice, we allow that somewhere closer to 6 weeks. Sometimes a little earlier, it really depends on the patient, but 6 weeks is our rule of thumb. And that's just because to be in that wet environment for an extended period of time, your tissue is still healing. And we don't want you to have any complications, nor does the patient. So that's our protocol. And with respect to getting the foot wet at that 3 to 4 days after surgery, Paul and I have actually published on this, both with a set of our own patients, as well as performing a systematic review of all the published literature back in, I think it was 2013-ish, maybe, or 14, and no increased incidence of infection or wound complications with early water exposure with getting showering.
So in summary, 3 days, shower, no scope.
Yes. Yes.
Terrific. Terrific. Thank you so much for getting into that. Some question too, will this affect my gait or affect my arches if I have the Lapiplasty procedure done?
So if we're talking about long-term, so once it's all healed, once everything feels normally, so we're talking a year after surgery, everything's healed, everything's good to go. If the surgery went as planned, it should, at least in our experience, improve gait. Because when you look at the studies of patients with bunions, they don't walk normally. They're not transferring weight from the back of their foot to the front of the foot normally because of the bones that we showed you that were out of alignment. And so with Lapiplasty, since we're putting the bones back very close, if not right where they should be anatomically, then the gait should improve. And we've seen in our patients, and actually we're looking at this right now, we're studying it, that other components of the foot actually can improve if we get the correction just right. And so, yeah, it's interesting that, again, the thinking has really changed with bunions. It's not just a bump, it's a structural deformity. It actually affects your overall function. And so it kind of follows that if we correct that and if we can actually get it back to normal anatomy, that should improve foot function. And that's what Mindy and I expect for our patients.
And then once I'm released, is physical therapy required? What kind of pain medication will I be on?
So great question. Physical therapy part first, that's really patient dependent. I would say the majority of our patients do not need physical therapy or feel the need for it. And that's, I believe, largely because we get them moving so early. We get them doing active ankle joint range of motion early. We get them walking on the foot early. So that really minimizes the loss of function of the foot and the leg and stiffness. If a patient feels that they're progressing slower than they would like, or if we feel they're progressing slower than we like, then absolutely physical therapy is a great adjunct to get them on the right track to recovery. And then with respect to pain medication, again, we can just speak to our experience. Because we have what we call a multimodal pain management protocol. So that involves what we do at the time of surgery. It involves the over-the-counter medications that we have patients take starting immediately after their surgery on a regular basis. Our patients take anywhere from essentially 0 to 3 narcotic pills in total during their recovery. But that's because, again, of our specific approach that we use, and we found that it's been extremely beneficial for patients.
Yeah, and pain management has evolved over the years. It used to just be, somebody's having pain, you give them narcotics. We don't believe that narcotics are effective for pain, and we believe that they have a lot of drawbacks and issues. And this protocol is very well established in the pain management world. It's not something that we invented. It's something that we adopted because it's just so beneficial for our patients. So we've gone from previous years where patients were really uncomfortable and miserable after bunion surgery to where our patients really kind of sail through it. We feel like they sail through it now, and they tell us, because obviously we're seeing them on a very regular basis and making sure that they're doing well and everything's going the way we want it to.
Thank you. Earlier, you both touched on, the severity of a bunion, if that, makes you more or less of a candidate. This one is more around age. Can somebody be too old to be a candidate for the Lapiplasty procedure? Or is there ever a point where it's too late to get this?
So I'm going to answer this first because I just had this discussion with another patient today. That age is just a number. That is not, and I'm getting old, so I have adopted this philosophy. It's more than just age. It really has to do with the patient's overall health. So good circulation, good skin and soft tissues, good bone structure, active person in their 70s or even into their early 80s could be a candidate. That goes the opposite way too. If somebody has circulation problems or other issues, they may be younger than that and not be a good candidate. So that is something that really is dependent on an evaluation with your surgeon, because we're looking at more than just x-rays. We have patients send us x-rays and say, are we a candidate? And I say, well, your x-rays are a candidate, but I don't know if you're a candidate unless we have to see you. We have to evaluate many different aspects to make sure. So But it's true. It's not just a number, and I firmly believe that because I've turned 60 this year, so it's not a number.
Saying out loud.
Very nice.
He doesn't say that number out loud. Yeah, no, I agree wholeheartedly. It is just a number. We have to take the full physiologic age and health of the patient into account.
I think that's great. And while we're talking about that, the whole AMI candidate is a very common theme we're seeing come through here. So if somebody, and this is kind of a multi-part, so I'll let you all address it how you would like to, but we touched on it earlier, but if somebody has arthritis, rheumatoid or even osteoarthritis, could they still be a candidate for Lapiplasty?
They can, and again, this gets into a deeper discussion than what we have had tonight. So we use the same philosophy. We use the same triplane correction. We actually use the same instrumentation and plates. But when there is arthritis, when there is rheumatoid arthritis or degenerative arthritis, when there's possibly a revision from another procedure that didn't turn out the way that it was expected, there may be slight variations on how we do the correction and plating. But the result, and again, we've published on this multiple times, can be the same expected result that we expect with the Lapiplasty that we've talked about tonight. So Lapiplasty really encompasses 3 or 4 different variations in the theme of what we were talking about tonight. So the short answer is yes. I really can't answer it in any more detail without a lot more putting out a lot more information than we have available tonight.
Okay, very good. And then we've got some attendees here who are definitely on their feet a lot, it sounds like. We've got a chiropractor, a hairdresser, even a professional dancer it looks like joining us tonight. How long should somebody expect if they're on their feet a lot for work for the job to have to take off work before they could return, if they're going to be standing and not able to sit down?
So if you can't use a knee scooter or be off of your foot, again, we're pretty firm on at least in our practice, on our regimen, that the safest thing is to be on your foot weight bearing 10 minutes per hour. So if you can adjust your job duties to be able to do that, where you're up and walking, within that 10-minute limit, but you can use a scooter the rest of the time. We have a lot of teachers that do that, where they're in the classroom, they're on their feet and in the boot, but when they've got to go across campus, they use their scooter. So that would be one good example. If you simply have to be on your feet 8 hours a day, so say you're a server in a restaurant, say you're a carpenter and you climb up and down ladders, you have to be off until the bone is healed, and that is somewhere between 12 and 16 weeks to be able to really be able to safely do a very high intensive job where you're on your feet all the time. So I mean, I can tell you we've corrected surgeons who have gone back to surgery after 3 or 4 weeks, but they modify, they change things, and that's the whole idea. It really needs to be a collaboration with your surgeon to figure out, hey, what can you do to modify your job activities to be able to fit within the safe parameters for recovery.
Yeah, and if I can, Derek, one thing that, you mentioned a dancer. So realistically, they're probably not going to be dancing until closer to that 16-week mark, but they can be doing upper body, they can be doing core, they can be doing proximal limb, hip and knee things. So they don't have to be bed bound, sitting in a chair doing nothing. They can do a lot of other activities to maintain their overall health and activity levels. So that way, when that bone is healed, strong enough for them to get back to whatever activities they want or need to do, they're ready to hit, quote unquote, hit the ground running, so to speak. So yeah, they don't have to feel like they have to be just sitting doing nothing, eating potato chips. You can be
We encourage our patients to be up and around. We encourage them to go to the gym. They just can't do jumping jacks and lunges. They do upper body, core, proximal leg, or the upper leg exercises. So that's really important to keep up not only your physical health, but let's face it, your mental health.
Would somebody be able to lift weights if they were to go back into the gym?
Not squats or foot involved weights, so no leg presses or standing squats, but they could go back and do all the upper body, all the core, all the seated exercises that they want. Yeah, absolutely.
Okay, very good. Let's see, we mentioned earlier when we were kind of touching on the, if somebody could be too old. Is there a point where how young can somebody be a potential patient? They're curious about if there's still growth plates, does that affect it? And, getting into sport, like youth sports.
Absolutely. So that's a great question of age, and it's when they reach skeletal maturity. So that is typically going to be somewhere 14 to 15 years
when
of
they're
age.
done growing.
Yes, I'm
Skeletal
using fancy words. When their bones or skeletons are done growing, so when they're mature, that's when we can do the procedure. So we don't want to do anything prior to that, because the growth plate where the foot's still growing happens to be right where we do the procedure at, and we don't. As you probably can guess after this presentation, we don't want to compromise. We don't want to do less of a procedure than what the patient really needs for the rest of their life and their good long-term outcomes. So once they're done growing, the growth plate is closed at that area of the foot, then we can proceed. And we get the question, and this is probably where this was kind of going to, oftentimes, well, if you're fusing that joint, is my foot going to be too stiff? Am I going to be able to run? Am I going to be able to play sports, do activity? And the answer is no. The joint that we are doing the procedure at is what's called a non-essential joint. So in a normal foot, that joint shouldn't have very much movement at all. The movement comes from the joint surrounding it. In a bunion, obviously, the bunion occurs because there is instability at that joint. There's too much movement there. So when we stabilize that joint, it does not, once you're healed, at first it can feel stiff because your body's adjusting to it. It's been used to that joint being unstable or kind of loosey-goosey, so to speak, for a long time. So once we stabilize that and you heal, then you should be able to, assuming healing goes as we would expect, should be able to get back to all your sporting activities, running, jumping, football, basketball, whatever it may be, golf, without that impeding or feeling stiff or awkward for you.
Okay, that's very good. And this is I'm going to appreciate that you guys getting into the additional detail, because we've had a lot of other questions too, just about activities like, when back to bowling, riding a bicycle, and things like that. So it's good. It's good information to know.
So some of the lower impact activities can start earlier. Things like bicycling, especially a stationary bike, which is, it's safer than being out on the roads. An elliptical, sometimes that can be safe in the 12-week range, but if you just, for a kind of a across the board recommendation to get back to sports, we're usually recommending 4 months, and that's just based on normal bone healing. It takes that long for the bone to get strong enough to be safe to get back.
Thank you. And this is a good one too. I know we've spoken about pain a lot and kind of talked about it in different thresholds, but person's got a bunion. They mentioned it's moderate to severe, but they said they're not in any pain at all. What would be your recommendation for someone who definitely has a bunion but isn't experiencing any pain as a result of it?
That's one of the questions that we run across a lot. Our approach is that we talk about what a bunion is, like we did tonight. We talk about what the potential pitfalls are if you leave a bunion, like we talked about tonight, the hammer toes and arthritis and all of those factors. And then ultimately, it's up to the patient to decide. It's not like, when you have appendicitis and your appendix is going to explode, you don't have a choice. You're going to surgery, right? With bunions, you can have surgery. You can choose to have surgery to try to prevent those future problems, or you can have surgery to prevent, to relieve the painful symptoms you're having now. So all of these things are considerations for why to have surgery. But ultimately, it really is the patient's decision. And we don't tell any of our patients that, look, you need to have bunion surgery. We try to lay it out in a educational manner. This is the problem you have. This is what we could expect. This is what could happen. And these are the treatments that are possible or that we can do for this procedure. And of those treatments, here's the good points and the bad points of each treatment. So really, it's a big discussion with your surgeon, but it's a partnership between the surgeon and the patient. And ultimately, the patient has to make the decision. Except for your appendix, you probably can't make that decision yourself.
Don't want to mess around. Don't want to mess around there. So.
Yeah, exactly.
Could my bunion be causing the pain that I'm experiencing over the distal or my mid or second metatarsal? And would getting this procedure done relieve the pain I'm experiencing in the middle toes?
I tell you what, that's a great question. And the real answer is yes, it's probably causing it, because that deformity of the big toe and the first metatarsal means that whole segment is not working. And then your second and your third are taking up the slack. We see that all the time. And we're in the middle, we're actually in year 4, not the middle anymore, we're winding down year 4 of a 5-year prospective study looking at Lapiplasty outcomes. And that's one of the things that we're studying. And the really, really absolutely rewarding thing is that patients that have that pain before surgery, it goes away after surgery, at least in a very high percentage of the patients. And it makes sense. I mean, if you remember the slides we looked at, we're putting that big toe and that first metatarsal and those sesamoids back in their functional position again. So they're going to work. And that means they're going to take some of the pressure off of that second and third. But that is a extremely common thing that we see in patients with bunions.
Yeah, and I just want to add, I do want to add kind of a caveat to that. That's what we see with Lapiplasty, because again, with Lapiplasty, we're focusing on all components of the deformity. So we're not only bringing that first bone closer to the second bone, we're rotating it, and we're also bringing it in the appropriate up and down position. So bunion surgery in general, if you're talking about 2D procedures, does not necessarily achieve the results that Paul just mentioned, because it's not affecting all 3 planes of the deformity. But with Lapiplasty, because we're truly lining up the bone to normal anatomy, that is exactly what we experience.
Well, and that's actually a great point. And I guess I just see everything as Lapiplasty now because that's what we do. But with other procedures, other than Lapiplasty, it's extremely common that surgeons will actually cut the second or third metatarsal to try to either elevate it or shorten it to relieve that pressure. And I can just tell you, Mindy and I almost never have to do that because we're realigning it. So we feel that's been a huge change in how we treat patients, because with many traditional bunion procedures that you don't expect that pain under 2 and 3 to go away. So.
Thank you. That was very helpful. We definitely had a lot of questions, coming in around that, so I appreciate it. And we had one follow-up here, kind of going back to when you were talking about exercising and weights. For exercises like squats, leg presses, was the suggestion and the recommendation this is something we couldn't do within maybe the first 6 months or so, or you would recommend not doing ever again?
Oh, no, they can absolutely, once they're healed, that's something that typically around that 4-month mark, because if you're doing squatting, lunging activities, that's putting a lot of strain on the foot right where we're doing the procedure. So we want patients to wait until that 4-month mark to bring back most of the squatting activities, especially weighted squats and lunges. But they should be able to get back to doing those, again, just like any other sport activity, once they're healed without any difficulty.
Yeah, we don't expect any. Hopefully we didn't say that or didn't come through. We don't expect patients to have any permanent restrictions from activity. The restrictions are while the body is healing. So that first 6 weeks, that's that 10-minute per hour rule, and then from 6 weeks to 12 weeks, you're in a running shoe and you can't do any running or jumping or high impact activity. But once you, for most patients, and everybody heals different, but for most patients, by the time they get to that 4-month period, then they can return to all of those activities.
Activities, we get the shoe question a lot too.
Yeah.
So activities.
Leading into, yeah, exactly. You're reading my mind. You're leading into my next question. It took longer than I thought it would to come in tonight, but an oldie but a goodie is, will I ever be able to wear high heels again?
Well, the answer is you probably shouldn't, and that's coming because it's just not good for your feet overall in general. But most patients, again, everyone does heal differently and feels differently after they heal. But our average patient, what we expect with the standard Lapiplasty approach that we've discussed tonight is that you should be able to wear whatever shoes you want to wear comfortably.
You know, there's just a caveat, and again, there's a lot more to this, you know, that we didn't go into tonight that we would if a patient came in for a consultation. But if there's arthritis in the big toe joint, that changes things, and we can't cure or erase arthritis. So that's one situation. If there's arthritis in the big toe joint, that may preclude being able to wear you know, the really big high heels.
You mentioned earlier, you talked about how you recommend a patient spending, you know, some time on their foot early on and kind of working it, things of that nature. If I'm in a boot, is there any risks of blood clots during this recovery time period, or is that why you're suggesting somebody be up a little bit on their feet? If you could, you know, maybe talk a little bit more about that.
Well, blood clots are a risk after any surgery, and one of the things that one of the main factors or risk factors is being sedentary and not moving. And so, yes, that can be the risk of blood clots can be helped by moving. So that's one of the reasons why we want our patients moving early, but that's not the only reason. The swelling is better, the soft tissues heal better, the sensitivity of your foot is better if you're using it. So that's why we want our patients to be up for that 10 minutes per hour. We don't have our patients in their boot when they're sitting or sleeping, like I said earlier, at all, because we want them to be able to move their foot, move their leg, move their toes. So yes, that does help with blood clot prevention. Now, just to go one step further, some patients have a hereditary or other predisposition to blood clots, and that needs to be identified by, you know, their surgeon and dealt with appropriately. That's not necessarily just early weight bearing.
Okay, thank you very much. And in regards to, you know, what you're going through for you, the both of you specifically, in regards to your kind of post-op protocol, how frequently and for how long will you have your patients come back in for follow-up appointments?
Yeah, that's a great question. And obviously this is different for every surgeon. So again, I can just speak to what Paul and I and our partner Jessica do in our practice. We like to keep a close eye on our patients because, you know, we want our patients to have a fantastic outcome. We want them to get the outcome that we told them we were going to work hard to achieve and that they want. So we follow our patients very closely. Within the first 4 months, we're seeing them about every 3 to 4 weeks. So first visit 3 to 4 days, second visit at 3 weeks, third visit around the 6-week mark, sometimes a check-in around 9 weeks, just depending on the patient, how things are going, and then usually about 3 months and 4 months. And then we like to see them back at 6 months to make sure that, again, there's no residual issues that we need to address or physical therapy or any concerns, see if they need orthotics. And then we follow them to a year, again, because we want to make sure that any residual, you know, whether it was a little bit of numbness or nerve pain or whatever, which is uncommon, but we want to make sure that they're not having any issues and not have them feel kind of left out there to wonder, is what I'm feeling normal? Am I okay?
Sure.
scared to call because they'll think I'm complaining. We
Right.
want to see our patients and follow them closely. You might say we're micromanagers with that, but that's because we really we want to make sure that they feel comfortable to bringing any issues up, and we can address them early and quickly if anything does come up.
Does osteoporosis come into play when determining if somebody is a candidate for Lapiplasty?
It can. It just depends on the individual patient and the amount of bone density loss that they have. The issue with osteoporosis is not bone healing, it's the strength of the bone. So that would mean that with the plates and screws, if the bone is not strong itself, if it's soft, then they may not hold as well. And so the recovery may differ a little bit if there is a significant amount of osteoporosis. Excuse me, it doesn't preclude surgery necessarily, but that is a very individual decision that would need to be made, you know, again, based on a detailed evaluation and whatever testing was necessary.
Okay, thank you. In this one, I want to revisit one because it looks like we had some join us later, weren't able to get on at the beginning, but how long do you recommend patients waiting between having their second foot operated on?
3 to 4 months. That allows them to be out of their boot for a full 6 weeks. It allows them to be back up to nearly normal activity on the first foot. And then that allows them to have a very active recovery on the second foot, because now they've got a good strong foot on the other side to be able to get up and around. And we talked a little bit about both feet at the same time, which everybody asks because I guess it sounds like a good idea. It's a terrible idea. You don't want both feet done at the same time. It slows your recovery. I think it harms the overall results because you can't move as much. I know we probably said that 100 times tonight. You got to move, you got to use it, you got to be on it for it to heal within the guidelines that we've talked about. But yeah, up and around is the most important, or one of the most important things about getting back to full activity and healing well.
No, that's great. I appreciate the response. We'll say it loud for everyone in the back to hear, but so that's very good. I appreciate that. So this next one is a very specific one, but it's one we've had before in previous webinars. If someone has a Morton's neuroma too, would correcting the bunion help the neuroma?
So if it's truly a neuroma, then because what a neuroma is, it's actually degeneration and an abnormality of the nerve. So if they truly have a Morton's neuroma, fixing the bunion probably is not going to fix the Morton's neuroma. So in those cases, you know, whether it's non-surgical treatments for the neuroma or surgically addressing the neuroma at the time of surgery, we have that discussion with the patient. But in a lot of cases, we find that what patients think is a Morton's neuroma actually is due to the overload or the increased weight that they're taking underneath of the second and third toes and the ball of the foot, because the bunion is there and the big toe and the bone behind the big toe isn't bearing weight like it's supposed to, like Paul mentioned earlier. So in many cases, if we determine it's not a neuroma, but it has neuroma-like symptoms, then yes, by fixing the bunion, realigning the anatomy, getting the big toe and the bone behind it to bear weight like it should, will solve that pain and kind of numbness and tingling under the ball of the foot.
Yeah, I totally agree. So if it is really a neuroma, the bunion surgery is not going to help that. If it's just seems like neuroma symptoms, but it's not a neuroma, and it's this, you know, overload problem, then bunion surgery could help that pain.
Okay, thank you. I appreciate the thoughtfulness and the in-depthness of the answer. I know some of them get very specific, so we appreciate that. What could one anticipate and expect in terms of scarring on the foot? And is there anything they can do to help with the scarring, either pre-surgery or post-surgery?
Scarring is very individualized, has a lot to do with the amount of melanin in the tissue, has a lot to do with patients' overall elasticity of their tissue. Patients that are older actually tend to have less scarring than younger patients because their tissue actually heals a little bit slower, so it remodels as it heals. But what we can do as surgeons is try to make sure we're using the absolute best soft tissue techniques in minimizing trauma to the tissue. What a patient can do is not excessively move the foot. I mean, obviously we're talking about movement and we want movement, but if they get too active on the foot too early before they're released to or doing things that they aren't advised to do, that excess movement early on can increase the scarring. We, in our practice, and I know this varies, but we don't want our patients to put anything on the incision until at least 6 weeks. At that point in time, then if they notice that scars may be a little thick or concerned about it, using things such as vitamin E oil, silicone gel sheets. There's a lot of different things they can do if they're concerned about it, or if indeed they do have a little bit larger scar. But scarring for most patients tends to be minimal, but it does take time. You know, the body is healing it and it has to remodel the tissue. But usually by the time you get to 6 months or a year, for the average patient, there's very little visible scar.
I think, you know, Mindy alluded to this, but just to put it out there, I think it's expectations too. I think if patients expect to be completely healed and invisible scar at 6 weeks, that is impossible. It will never happen to any patient ever for any operation. Yeah. That's the way our body heals. I mean, all we can deal with is human physiology and biology. And the way our body heals is when there's an accident or an incision, your body puts down scar tissue, and it takes a full year for your body to remodel it to a nice, soft, you know, normal color, scar that you can't feel. You'll almost always be able to see a little bit of a remnant of a scar, but most of the scars, because of the way we do Lapiplasty and we do a very specific technique of dissection, by a year, they're soft, they're mobile, and they're minimal from a standpoint of being able to see it. But you can't stop scarring. It's impossible.
Thank you, and I appreciate the response about expectations. I think that is a big piece of it, what you expect, you know, versus what comes through, and just keeping those things in mind. Here's a good one. If I have diabetes type 2, is there anything I need to take into consideration if I'm interested in the Lapiplasty procedure or make my surgeon aware of?
So I can give you our protocol. So studies show that if your hemoglobin A1C is above 7, there is increased risk of healing and also increased risk of infection. So that's one piece of advice that I could give, is really need to have good, tight blood sugar control. We tend to like closer to 6 as a benchmark. If there's any other complications with circulation, if there is neuropathy present, those are all pretty big risk factors, and may even make it so that it would not be a good risk-benefit relationship to have the bunion corrected. So again, back to very individual, goes back to a detailed consultation with your surgeon to look at all of these factors and see if you're a good candidate. If there's no complications, if the hemoglobin A1C is in a very good range, then we have no issues with correction and don't see a big increase in complications.
Okay, thank you. And let's see, we got time for a few more questions here. And this one, I know we talked a little bit earlier, but just they're asking a lot. It's not an existing patient, but are there any issues with people having to have the hardware removed, or if they're experiencing pain where the plates or the screws might be in the foot? If that does happen, can the hardware be removed?
Yeah, you know, it does happen where patients get some irritation to the hardware on occasion based on their foot structure, their foot type, how much padding that they have in the foot. And so if that occurs, then yes, we'll remove the hardware once they're healed. I think I mentioned earlier that the good news is once you're healed and the bone is healed, the hardware is not doing anything for you any longer. It's just along for the ride. So we can remove that quite simply. We use the same incision, take it out. It's a very simple recovery because we're just waiting for the skin to heal at that point in time. So it's not going through the full Lapiplasty initial recovery, and it's not needed once you're healed. So your bone's going to stay in position. There's not concern about it drifting back and allowing the bunion to recur again. So we handle that, on a patient-to-patient basis. Thankfully, it's a very small percentage that needs that, but it does happen on occasion, and we take it out, and usually problem solved then.
Okay. And this one's kind of a good one. It kind of gets into the whole hereditary issue that we talked about earlier. We've got some people trying orthotics and different things of that nature. Will these in any way stop my bunion from progressing, or is that something that's going to happen unless I take a surgical approach?
There has never been a study that shows that an orthotic or a shoe change or avoiding a certain shoe will stop the progression of a bunion. Now, that being said, orthotics work great to treat symptoms in many cases, like the pain under the ball of the foot, which is seen with bunions. It can, treat arch pain and heel pain, and they're great for certain things. But an arch support or an orthotic is certainly not going to reverse a bunion, and there's really no evidence to show that it will slow the progression of the bunion. So then that gets back to what we talked about earlier, and that's the conversation with your surgeon of, what are the risks versus benefits of doing your surgery now versus waiting or not doing surgery at all.
Yeah, and sometimes we use orthotics as part of the recovery as well, because just by supporting the middle of the foot kind of close to the area that we do surgery, it helps take some strain off the foot and allow them to walk more comfortably during the earlier phases of healing as well.
Okay, thank you. That's great information and definitely good to know. And so we'll wrap up with this one lastly. If I'm interested in talking to you about being a potential patient, but I live outside of the Ankeny, Iowa area, how can I get in touch with you? What's the best way for them to find out how to reach the Dr. Daytons?
Absolutely. Well, you can go to our website and find out more about us and also schedule an appointment there. That's just www.footanklecenteriowa.com. On there, you'll find our phone number as well, or you can look us up on Facebook. We do have our patients once, if you reach out to us, we're happy to look at x-rays at first if a patient sends those, but we really need to see the patient face-to-face in the office to review all the things that Paul mentioned. We need to check circulation, we need to check feeling, we need to not only treat the x-rays, but look at the foot so we can determine what's going to be the best approach, and are you, truly a candidate for Lapiplasty or one of our variations of Lapiplasty if you have arthritis or whatever it may be. But our team can work to get an appointment scheduled for an in-person consultation. And then we do try to work on an individual basis with patients as appropriate to sometimes limit some of their appointments, not all of them, because again, it's important to us that you have the best outcome, and we want to be able to help guide you through that process. But we have that conversation then about how do we approach the post-operative recovery, and we have our patients then that choose to have surgery with us come in just a day or two before their surgery. We see them again because we see all of our patients right before surgery to make sure that they understand their post-operative pain regimen for medications, make sure sign the consents, make sure we're on the same page. So have them come in perform the procedure, and then again, whatever we determined was the postoperative protocol for them, we'll review.
Yeah, we feel pretty strongly. We do see patients from a long distance away, but we feel strongly that if we're doing the surgery, we really need to take them through the recovery and make sure that we give them the result that they were expecting from us. So, yeah, if patients from a distance away, we do ask them to come back for their follow-up appointments so that we can, again, make sure that we give them what they were expecting.
Terrific. Thank you both so much. So as we begin to wrap up now, reminder for all of you still on, and still have a lot of people here, which is terrific. So thank you all for participating tonight. As a reminder, if your question did not get answered, or you think of something later that you wish you'd asked and just didn't get the chance to, again, feel free to reach out to us. You can email us directly at patientinfo@trace.net. You can also learn more or also find local doctors in your area, again, by visiting our patient website, lapiplasty.com. Don't forget that as a follow-up, we will email all registrants an archived webinar link for reference within the next week. We hope that you found the information presented tonight helpful. Doctors Mindi and Paul Dayton and I appreciate you joining us. We hope you all have a wonderful rest of your evening. Doctors, thank you again so much for a job well done tonight. We really appreciate your time.
Thank you, everybody.
Thank you, and thanks everybody for joining. And good luck to everyone on your bunion journey. So thank you. Thanks for spending the evening with us.
Thank you very much. Good night, everybody.
Thank you.